Thank you, Rosie, very much, and thank you for the very kind invitation to speak today. I'm a cardiologist, and James is a clinical associate professor in Trinity Hospital. And just to get the rumours out of the way, at the start of the talk, I am not Sinead's other half. So we're going to talk through the various modalities that you need to put the complex jigsaw that is a cardiac amyloid diagnosis together, and you need nearly all of them to formulate the final diagnosis. And it's one of the reasons for the delay in interpretation and delay in getting the diagnosis is this exact issue. I've unrestricted education grant from Pfizer. We're doing a study at the moment in penetrance in the next generation, which is very, very interesting. So the tips to help in diagnosis are multimodality, and they basically involve everything that ranges from an ECG to an echo to a nuclear scan that you've read about this morning, a DPT scan. MRI has become a cornerstone of assessing tissue muscle. CT may have a role coming down the tracks, we'll talk about that. And finally is the old bugbear of histology, which is the original picture that with which we all got to diagnose cardiac amyloidosis. The ECG isn't really an image, it's a pattern, and we have what they call these pseudo heart attacks, pseudo infarcts. If you can imagine an ECG is reflecting the amount of muscle in a heart, the commonest reason to lose that muscle is to have a heart attack, a blockage, and that bit of muscle is thinned out. Amyloid does something similar. It decreases the amount of, or it covers the muscle with fibrils, and therefore there is less obvious height. If you think about this looks to an untrained young cardiologist like it's a heart attack, but in fact it's a pseudo heart attack, and it's one of the sort of myths around amyloid that you get a thick heart but a thin ECG, if you can think about it. ECGs are ubiquitous, they're nearly in every GP practice in the country, they're really common, and it's often a way to pick up an abnormality in the first instance, that there's something going wrong with this patient's heart muscle, because the ECG is small but the echo is substantial. That rule of thumb is not as effective as we thought it was 20 years ago, but it's still in use. Now, what are we doing with these echo ultrasound probes? We're harnessing technology that was first put together during the Battle of the Atlantic, when Europe was nearly strangled by German U-boats, in both terms of fuel and supply. What they did was they adapted the technology to send down a signal to the seabed and wait for it to come back. And if it came back too quickly, it was hitting something, namely a German U-boat. So within about 18 months of harnessing radar technology, they turned the battle in the Battle of Atlantic. It really saved Western Europe from starvation in mid-43-44. And this technology came to medical usage sometime in the 1950s. A Swedish radiologist went down to the local shipyard in Stockholm and said, can I borrow one of those things there, and started playing around with looking at human cavities to see what he could see. So now by the 70s we get really good cardiac ultrasound echo where you can see 2D images of a beating heart, and it's really quite a revolution and quite a recent one, all based around accelerated military technology. The infiltration causes a pattern on the left where the heart looks too thick, and the best way to exhibit that is to look at the one on the right, which is a normal heart muscle thickness. And you can see from the end of the room we have a different pattern going on together. This is the infiltration deposition of the amyloid that we're trying to avoid. There is not just about 2D ultrasound, although that's the obvious one. There's also looking at the patterns of movement of the muscle plate. This is Doppler, the even older form of sonar. And you stick the little cursor and you squeeze it onto the bit of the heart you want to study, and it gives you a waveform. And in amyloid, the waveform dictates how quickly, firstly, the heart is relaxing. So you've got to relax and pump, every cycle of every minute of your life. In that relaxation phase, if the heart gets stiff, it doesn't fill as well. If it doesn't fill as well, there's too much blood, and the blood flows out from the river into the fields around into your lungs, and that's how you get breathless. So early on in amyloid, the first thing that goes wrong is the stiffness of the heart, and that's how you show it by echo. And you get these incredible thicknesses in the wrong part of the septum there. Later on, you get where the squeeze, the second part of the cycle, gets weaker, and we can see that exquisitely by 2D echo going forward. There's a third trick, that the heart squeezes like a tea towel, one of the most extraordinary achievements of evolution. You get a tea towel, you squeeze it like that. When your heart pumps, it squeezes base to apex against each other. Incredibly effective way of expelling things from the tea towel. But you can study that pattern of what we call strain at tissue level by echo. And this paper next was by showing this strain pattern in a lovely bullet plot where the apex, the top of the heart, is spared. And this is what happens in amyloid. It doesn't infiltrate all of the heart the same way. There's an Irish link here. Dermot Phelan wrote this paper. He was an Irish SPR. He did his PhD in UCD and then went on to the Cleveland Clinic and was the lead author in this paper in 2012 and is still working in the field there. But this is very useful because it's so easy, because it's so graphic, because it's, like Julian was saying there, it's artificial intelligence hitting the pattern. And this is a pattern of 4 different types. The one on the left is amyloid, the one on the right is hypertrophic cardiomyopathy. But they're chalk and cheese opposite, aren't they? And you can see that without the aid of, and we could do this with a press of a button now on an echo machine to get the strain pattern out. And it's a very useful way of saying, this is not hypertrophic cardiomyopathy, this is the other. And it's a lovely, lovely advance in echo technology. I did my initial training in Dublin, then studied under Perry Elliott and Bill McKenna in London and St George's in the heart. And then I went to the Cleveland Clinic to do an imaging fellowship, which was a fascinating time. It was a very exciting time. There was lots going on. They went from, we were near a Philips CT data development site, a factory, and they went from 4 to 16 to 40 to 64 slice CT in about 5 months while I was training there. We're now at 526 slice CT. And in a similar way, in echo, there were changes going on. For years, the crystals in the probe, with which you've all had echoes, the crystals were slightly scatty, but Philips managed to get them all in a straight line, so there's 100% polarity, much better image quality, much more capable to miniaturize the probe. And the research for these pure wave crystals was in part sponsored by the US Navy, so they've not gone away. 3D echo was also vastly accelerated. Mark Twain said of Wagner's music that it was much better than it sounds. And for a long time, 3D echo was much better than it looked. And it wasn't until this type of crystal technology came to maturity in the last 5 years that 3D echo gives these extraordinary pictures of heart valves like that. Not particularly important for amyloid, but just to tell you what's going on in the imaging field, and it's getting better and better only. You can get miniature portables attached to a butterfly, you can put it to your mobile phone and do a really good echo now. So echo is portable, fast, ubiquitous. The other scans you talked about are more cumbersome. MRI is 45 minutes, it's expensive. DPD is not widespread. MRI, on the other hand, is the best way to look at heart muscle. Better even than echo, and I'm the echo fellow, but I say this with regret. This patient has got fluid around the outside of the heart, something's wrong, the atria are too big, the muscle is too thick, and basically it's the picture perfect of amyloid. It's one of the major ways we pick it up in the Republic anyway, is in the widespread use of cardiac MRI, and they say, well, that could be amyloid, and they come back to us with the diagnosis after the fact, and it's one of these sort of weird effects of the public-private mix in my society. That's gone off. So we have gone from the late 40s when Isidore Rabi in Massachusetts Institute of Technology won a Nobel Prize for the physics of MRI, to the first prototype in 1980, where the first diagnosis was made in Aberdeen of that extraordinary machine you're seeing on the left, something from Willy Wonka's chocolate factory. You're glad to say things have got a bit more streamlined. It's still cumbersome. The physics behind it is exquisite, but all of you who've had an MRI know it's like being inside a steam train. It's noisy and loud and it takes 45 minutes, but the science behind it is immense, and it took a century of brilliant physicists to get to the stage of this beautiful streamlined machine with which we can get really detailed machines. And it's not just about the shape of your heart. The shape is important. This is a different disease, but you can see from the shapes, some people have thicknesses at the top of the heart, some of the base, and some of it's concentric. In light chain amyloid, it's usually concentric, but in TTR it can be quite asymmetric, and having the capacity to define the shape will lead you to suspect one direction rather than the other. And it's a lovely way to look at things. It's not just the shape. There are multiple sub-ways of analysing this. I won't go into them all, but think about one of them is the extracellular volume. Why would you have stuff outside your heart cells? And it's the fibrils. They don't get into the cells, but they increase the amount of material in your heart that's outside your cell. And therefore you can calculate that, quantify that really clearly with MRI. MRI is a fantastic tool in terms of rigorous quantification of what they're going on. They've really worked very hard. And the mapping is a different issue about the way they flick electrons back and forth there. But you can get very, very good pictures of it. CT is, as I said, one of the things I like to do. There is starting to be a literature around the use of cardiac CT, again looking for that extracellular volume. This is going to be very interesting because CT technology is very, very sturdy, very repeatable, very long-lasting. MRIs sort of have personalities. They can go off and they go on, have bad days. CT is very, very consistent, and on that basis, if they can develop these research areas, I think CT may have a role in imaging for cardiac amyloid in a more realistic pattern going forward. And it will also be much quicker in terms of acquiring the images there. I don't know, have you picked up, but cardiac MRIs are very unpopular in the general hospitals because they take so long. You can do 3 cancer patients in the time that you get 1 cardiac, so they sort of pushes to the side, whereas the CT would be a great way forward. The other great breakthrough of the last decade and a half or so is the surprise, unexpected utility of nuclear scanning. Nuclear scanning is very old, it's real 1950s, 60s stuff, and it was developed to look at prostate cancer secondaries, melanoma secondaries, and it was noticed in 1977 that a guy who had prostate cancer but also had amyloid was known to have a hot spot here. And as you go from left to right there, you can see more and more uptake in the heart, indicating higher and higher levels of uptake of amyloid fibrils there. And this is one of the ways that we have to prove to get your reimbursement for things like tafamidis, is that you've got a grade 2 or a grade 3 or a grade 4 of this particular scan. They're pretty neat and quick. As I said, it's old-fashioned technology, and it's a technology where you inject something that's radioactive into a patient, and he or she the detector picks up the patient's detector rather than bombard them with sonar waves. The patient is giving out the signal onto the scanner, and it produces a very nice and, again, reliable picture of what you're looking at. This has almost completely displaced the use of widespread cardiac biopsies, which, as Alistair was saying earlier, is a good thing there. Go one forward there. And again, the DPT, as I said, is very graphic, very obvious, and the involvement there. That bladder is lighting up because that's where the isotope ends up later on there. And in other courses, this is a TAVI valve, which is an implanted aortic valve up the leg. Mick Jagger had one now, so it's very fashionable in America. No one over 65 wants to have an operation. They want to have Mick Jagger valve. But they discovered that in the older groups, up to 14% of them had 2 diseases. They had aortic stenosis, all right, causing hypertrophy, but they also had amyloid. It was just because somebody's dead. And it was picked up accidentally by these sort of scans at 2 different centres very quickly, one from Barts in London and the other from Columbia in New York City. So DPT nuclear scanning has largely replaced routine invasive biopsies. And biopsy is, I say that with slight sort of regret, nostalgia. Biopsies are part of the canonic central way of assessing what's going on in this patient. And part of the reason that the Irish and Scottish schools of medicine became so famous in the early 19th century across the world was that they went back to tissue. Say, this patient in this biopsy last week, there is amyloid. And I always say you never rush a pathologist because there's only one worse thing than a slow report. It's a wrong report. And they sort of are at the very centre of individualised medicine before the phrase was invented. This is your heart, this is your biopsy. And so when we were doing these biopsies, we still do a few, you get this extraordinary birefringence pattern. You can see it lighting up as orange there. And it's very pathognomonic of amyloid, and it is sort of the final frontier in terms of real diagnosis. Because some people have overlap light chains, about 3% of people, as the next speaker educated me, 3% of people over 70 have light chains as well as amyloid. You sometimes have to revert back to biopsy. So we still do the biopsy. We do it through the neck veins, the internal jugular, or through the leg vein, the femoral. It is invasive. There are complications in a small number of patients, but it is, as I said, the real deal in terms of getting through. So I regret that we're not doing as much as we should do. And you get electron-micron biopsy. We send these to UCL, where they look down at an electron microscopy, and you can actually see the fibrils that we're talking about today. It's an astonishing piece of development of picture taking. So early diagnosis with better imaging is critical. We need different types of imaging. And if you see thick heart muscle with an abnormal ECG, you should be thinking amyloid. You need to be careful where you get treated. This is one of my favourite pictures that I've ever collected in my life. This is in Cleveland, when the nurses would go on a hen or a stag, they'd often go to Las Vegas because it was within a short hop. And our patient went to Las Vegas to play in the slot machines, and he began to win money, and then he got chest pain, and then he needed an emergency bypass. So he got his bypass, and to be fair to them, they got the bypass. But when they were closing up his stitch, his sternum, they put in 4 big wires to stabilise the sternum. They're doing all bypasses, except by some astonishing way, they managed, in the 3rd one, to skewer the top of the heart. So he came back to us, his chest pain was gone, he was getting funny infections, so we sort of had to work out this. The moral of the story here is you need to pick the right imaging test, and it wasn't until we got this CT scan that we realised what was going on. We took the wire out, he was fine there. But the moral of the story is pick the right imaging test for the disease that you're trying to investigate, and you need more than one for amyloid here. I'll end with that, but I often like to think of this patient as a man who went to Las Vegas and came back with a bypass and a kebab. Thank you very much.